Okay, let's get started. Welcome everyone to our webinar today, Pain Management Post-COVID. We're glad that you're able to join us. So we're going to talk about both pain management post-COVID and best practice pain care and how to participate in US Pain's virtual advocacy day. So COVID-19 has had a really significant impact on people with pain. We know that pandemic precautions have led to cancellations or delays in treatment for many. Financial hardship has meant that many treatments with high deductibles or co-pays or co-insurance are unaffordable for many. Pain care has become even more fragmented over the past year and a half during COVID. And the isolation that's common to the pain experience has really increased, vulnerability for patients with pain who already live with a fair amount of isolation. So there's a greater need now than ever before for improved pain care. Patients need access to the type of care that was recommended by the Health and Human Services Best Practices Pain Management Task Force. The Pain Management Task Force report was mandated by Congress in the CARA legislation, and it calls for individualized, multidisciplinary, coordinated care. And to discuss the impact of COVID on pain care and really explain the need for better pain care now, which is our hashtag, I want to introduce Dr. Vanila Singh. Dr. Singh is practicing pain management physician at Stanford University. She is clinical associate professor at the Stanford University School of Medicine. She was the chief medical officer for the US Department of Health and Human Services Office of the Assistant Secretary for Health. And most importantly for us, she was chair of the Health and Human Services Pain Management Best Practices Interagency Task Force. I had the pleasure of getting to work with Dr. Singh when I served on the task force. Her leadership of the task force was exceptional, and her sincere devotion to the welfare of pain patients and improving pain management really comes through when you work with her and get to know her. We at US Pain are delighted that she agreed to speak with us today. And welcome, Dr. Singh. I'm going to allow you to share your screen now.
Great. Here, I'm going to move to my screen and let's hope. All right, there we go. Cindy, thank you so much for inviting me here today, the US Pain Foundation, for this very important time where you all do such a great job in terms of advocacy, getting on the Hill, making sure people don't forget. There's so many people who feel forgotten. And for that, I'm so grateful. And I did have a wonderful time working with Cindy under very tough circumstances in the US government, pulling the task force together with the Department of Defense, the VA, and she represented patients, and we were able to bring patients from around the country, and all of them were so proud of Cindy's work on their behalf. And that is something that is forever the guiding light for all of us, is that ultimately it's really, we're doing this for the people, patients who are suffering greatly and unfortunately unnecessarily in this day and age. And so with that, I'm just going to talk briefly about what has been going on. Let me try to get my share here to where I can put this in the slideshow mode and kind of take it from here. So we all know that in essence, the pandemic has had a huge impact on everybody. But the impact on medical care and patients with chronic painful conditions has been unbelievable. And really it's because of the devastation that has come from a financial concern, a social concern, people feeling isolated, and that fear leading to an odd time in life where even meeting people would, at a time you need them, you were really actually being advised to stay away. That personal isolation and fear and panic had led to folks even impacting their professional ability, again, leading to more financial concerns, work stress, and ultimately worsening and exacerbating an already challenging quality of life, even for those, whether they were working, but their own routine, which oftentimes is 24 hours a day of just trying to ensure you can manage your routine, maintain your independence, and maintain your dignity. All of that was put on hold and exacerbated, and really led to a challenge, I think, that was unforeseen, where our own patients who were already struggling were suddenly not able to get the care that they needed, whether it's treatment, injections for acute flares, whether it was medicines, it was, or reassurance to talk about possibly new symptoms. All of that was put on the back burner. And what it led to was a collision, really a collision of a challenge of social isolation, lack of medical care, no access, and of course, the great fear that gripped all of society and the world with the novel virus. And this action led to lockdowns and restrictions that furthered this. And we had reactions as never seen before, where it went from bad to calamity. If you think about people, even in other realms, and I know patients with painful conditions are the most empathetic to other folks, many people would let me know that their friends or relatives had sobriety meetings canceled in person. There was no structure, and adverse mental health effects were affecting an easy 50% of our population. And for a while there, all medical treatments were on hold. We know this in chronic pain, but think of it even in terms of late diagnoses of cancer. This is real, and it's happening all throughout the United States, that understanding that people are presenting much later in their disease process. I wanted to highlight, back in December of 2020, almost a year ago, I had put an article out in the Stat News talking about some misguided federal regulations that were happening right in the midst of these horrible situations where people were left isolated, didn't have easy access to care. And at the same time, CMS was coming out with more requirements of pre-authorizations for certain procedures. And again, remember, we need all the tools in the toolbox for people who are suffering. And this was going to only put up more barriers. And of course, we highlighted those barriers for examples like Botox for chronic migraines or spinal cord stimulators. And of course, we went into the challenges for still trying to get the needed medicines that gave people some functionality and some quality of life, those being on hold even more, while mental health issues went. And we also saw, of course, the skyrocketing of illicit use. The NIH here, and I put this in a turquoise, I was just so unhappy with it, but the NIH itself was talking about this on their website, where you see it says, the COVID-19 pandemic is fueling the opioid crisis. And it gets into it in terms of identifying why, in terms of people having challenges with eating, sleeping, isolation, mental health exacerbations, tens of millions of people. But their focus remained on the misuse of prescription pain medicines, when in fact, we saw a major drop in prescriptions, and of course, a rise in opioid overdose fatalities, which were linked primarily to the illegal use, the illicit drug crisis. And here again, they mix it up. They were right that the pandemic was fueling the crisis. They were wrong in terms of mixing the two possibilities of what was doing it. And what is really going on with different people during this challenging time? Well, I was going on different smartphones and seeing all this stuff. So I said, you know what, this is how they just put a screen on a tech device and think like that's it. But the truth is, it's real humans. We know on the left, it's social isolation, as I mentioned. this really brought the risk of of distress, relapse, easy triggers, no structure in life, depression, loneliness, and fear. And of course, health and wellness in general also took a back seat. Eating, exercise, the reach out for help. There's really no one around. And if it wasn't COVID related, it was really on the back burner. And again, half the population highlighted 1,000% increase in emotional distress. We all know that mental health was already in our society taking off in a back seat. And you take that and you make things far worse. It doesn't matter what medical condition you have or don't have. It exacerbates and worsens your life. It makes you more unhealthy. It makes blood pressure, diabetes, all these things worse. And of course, the challenge for already challenged patients with chronic painful conditions was made far, far worse. Another thing from the NIH, I've already gone into it. They highlight all these things. They felt that there were 4 major elements of recovery that may be disrupted by the pandemic. Health, of course, home, of course. Many people were left in their home, which may not have been the greatest circumstances, with other family members, lots of stress, lots of room for discord and arguments, and not necessarily a great place for young adults or teenagers. Purpose, conducting meaningful daily activities, and having the independence, the income and resources to participate in society were all hindered. And community, something about all of us being human. I think there's one great appreciation of the importance of value that it has in our well-being, having relationships and social networks, being able to go to, whether you're a spiritual person, go to your church or temple to get support, to see your friends, just to have your normal routine. We're all, of course, on hold. So non-COVID medical matters were on hold, and we saw that, and again, I had put this out in the December 2021 article. I went back to look at it because I was like, well, what was my mindset then? Was I already, were we trying to fight this? And the answer is yes. And I pulled out a quote where it says, one of the many consequences of our nation's response to COVID-19 has been the cancellation of non-essential procedures, which has limited access to non-COVID-19 related medical care. It has affected millions of Americans and made matters worse for patients with painful, debilitating conditions, leading to worsening of pain, increased suffering, and poorer outcomes. That was in the midst, again, prompted by CMS, in the midst of all this, again, deciding to put up more barriers. It was almost unconscionable that could even be occurring, particularly because commercial insurances and CMS all saw in the last year and a half that with people having less access to usual essential care, their costs were all savings for them. And to then decide to put up more barriers, I felt it was highly indicative of the complete disconnect of what was going on. Commercial insurance premiums never went down. Nothing changed with Medicare. They were, the government had programs to try to help people in other ways. But if you look at it purely from this manner, they were trying again in this vacuum without a real understanding of really what was going on in society. They're still concerned about overutilization. And it was at a time when there was almost no utilization. It's just a great disconnect. And just to review, I know the audience here is so savvy, and I really, again, thank you all. And hashtag pain care now is so important. Just to review really what we've seen. These are old. This is the first wave of prescription deaths that they attributed to natural and semi-synthetic, and that's really throwing all prescriptions and illicit fentanyl in one batch, right? And then we knew that heroin, which was the orange line, was going up, and methadone was sort of out here, mostly because it wasn't used much. The second wave, well, I skipped that, I think, because people knew, but the third wave up to 2017 highlighted, again, this sharp, rapid increase, and this is data through 2017, that we were seeing on the task force. And again, they call it synthetic opioids outside of methadone, but that included the illicit drugs in it. They only separate out the non-opioids, which like cocaine, you could see was just on a rise, and methamphetamine. But this here was really more than anything highlighting the illicit fentanyl and its analogs. The fourth wave was the cocaine and methamphetamines. This is with opioids. So they said, oh, it's with opioids is causing all this death, but actually without opioids, pretty significant, meaning they were doing and causing death of its own. This is amphetamines and cocaine. These are non-opioid illicit drugs on the rise, highlighting that the illicit drug crisis was stemmed and fueled by other factors. And when you think about what are the other factors, just take a hard look at what was happening in the United States. People had lost their jobs. This was most pronounced in West Virginia. And that's actually the state that had the worst problems. It was the misuse, people stealing and borrowing other people's prescriptions. And it was important to take a look at why was that happening? Was it too plentiful? There was, of course, a role in that. But to address this and therefore conclude that this was a problem with all pain patients and that pain patients were the problem is unforgivable. So here the data is to 2019, and here again you can see that any opioid, which means also an inclusion of illicit opioids, was on the rise. This is from the National Vital Statistics System mortality file. It's part of the government. Per 100,000 people, the rise of overdose deaths, okay? All opioids totaled, black line. Purple is where you have the synthetic opioids. And this is prescribed or illicit, right? Meaning it's not commercial fentanyl that we've always found to be the problem. It's the illicit fentanyl coming from abroad. That's part of this group right here. This is minus heroin and minus methadone. Still a huge rise. But what's really important to see is commonly prescribed opioids in the turquoise started to teeter off. No surprise to anybody. Same with heroin use. So really the purple line represents the illicit opioids that were still on the rise into 2019 after all the dramatic and drastic effects taken across the country with state laws based on the CDC guidelines, with the medical boards coming down hard on doctors, with the DEA continuing their efforts to curb controlled substances. We saw a decline in commonly prescribed opioids, absolutely. The fear is palpable. The cut down is real, happened at the pharmacy level, at the provider level, at every level. And yet the deaths per 100,000 in the population continued once again, saying a story that we already knew was true. Let me see if I can. Oh yeah, here's the next one. My really excellent friend, who I encourage everybody to follow on Twitter, as well as me, please, Josh Bloom. He's with the American Council on Science and Health, and I asked Josh to give me some slides because he follows this as I do, and he's just been a wonderful resource and very knowledgeable in the topic. This is from Pain News Network. But what we really did was take the prescription opioid analgesics, and by year on the left graph, you see from 2011, around then is the peak, 2010, 2011, and a significant drop to 2018, 2019. Almost to levels where perhaps we'd say maybe 2003. That's significant. It's a huge drop again. And then on the right, you can see, again, age adjusted as the 2016 guidelines had come. We know that in males, there was a drop total females and males drop and females drop. So categorically hitting everyone in terms of the drop in prescription opioids. In this graph, also provided by Josh Bloom, the left graph highlights that meth seizures from 2006 to 2016 had a rocket rise. San Diego, of course, being where a lot of it is because of the border, the porous border, and where a lot of it was coming from. That's San Diego, there's Laredo, Texas, Tucson, Arizona, and other US cities, but all of them beginning to show that rise. And it's explicitly seen in the city where there was much easy access. And once again, on the right, you can also see street meth purchases in America, where the dollars, the value, the expense went down, purity went up, and there was much more use of it. This is the Drug Enforcement Agency. And in this one, I just pulled this from the national, this is really on the SAMHSA website, and it's from 2019, which seems like, again, it's old, but this is pretty much as fast as the government gets it. So this is the most recent statistics they have. And the illicit drug use, which we now know is, of course, the primary issue fueling the drug crisis and the overdose deaths that we see with mixed dirty drugs. Marijuana is the #1 significant increase from 2018, about 16%. We know the factors that are playing into that, of course, that it's coming mainstream, but the concern is that not all of it is understood or mainstream. Some of it may be some strains put into some mixed drugs, so has still some concern. Psychotherapeutic drugs, 16.3 million, next highest illicit drug use. Hallucinogens, 6 million. Cocaine alone constituting 2.2% or 5.5 million. Inhalants, 2.1 million. Methamphetamines, 2 million. Heroin is all the way down there. Sorry, I just moved my screen. All the way down there at 745,000. So these are the illicit drug use. And the major concerns, it says in the title, is opioids, marijuana, and methamphetamine, but opioids are all the way down there. And that, again, is specifically heroin. It is marijuana #1, and then methamphetamines, cocaine being higher than methamphetamine. Oh, here we go. Okay, so dedication to provide the data, what's really going on. We know prescriptions are less. In the lower right, small graph, really simple graph that's highlighting it's a timeline versus prescribing rate per 100 people, clearly a dip. Various different articles written recently that's trying to analyze. One is, of course, by Stephen Nadeau, Jeff Wu, and Richard Lawhern, Opioids and Chronic Pain. They go back and try to do a review, and they try to be very even in their understanding about what's happening and the relationship of depression to chronic pain and its treatment. And to not treat is really what leads to these tough mood disorders. What are patients saying? They're saying the same thing that they felt before, but worse now, felt on an individual basis. They were being forgotten. They're being forced tapered still, even though the FDA, even though the HHS, straight from our task force, all of these warnings went out about the adverse effects of forced taper that could even prompt worsening of other health conditions. Patients abandoned, absolutely. So many pain clinics closing and primary care providers saying, no, we don't have the license. We don't do opioids. With them having nowhere to go, very few places such as Stanford, where I practice, are places we take them. And it's a very challenging situation altogether. Feeling guilty as charged and stigmatized, even though patients who suffer from substance use disorder and addiction are getting great empathy and understanding. And I think that's great, but to see how patients with chronic painful conditions, secondary to MS or Parkinson's or lupus or Ehlers-Danlos or sickle cell or radiculopathies from degenerative changes that limit their ability to function or work or run a company, are all being looked upon with more callousness than ever before. And one thing we wanted to emphasize, I've done a talk on this with patients over protocols, is how suggestive guidelines, which I'm referring specifically to the CDC guidelines, can spin out of control and end up ultimately hurting the individual patient. The CDC guidelines in 2016 themselves admitted that these were specifically for primary care doctors and chronic pain patients. And of course, that has gone far beyond it to where we have state attorneys generals and people putting it into state law with no context, no clinical understanding, no awareness of what other treatments our patients are having, why they're having, what are their medical conditions, the variety, the dozens, the hundreds, and have gone there playing doctor with, of course, no license, no understanding, no empathy. Another thing I wanted to share to everybody is from our task force report that Cindy talked about. This was from a congressional act of 2016, the Comprehensive Addiction Recovery Act. It's very prescriptive. And we have a huge report that is written responsibly, objectively, extremely balanced. It is not for or against any particular treatment because we're not talking about a particular condition. What we are talking about are clear issues that have come from tens of thousands of patients and science and 500 scholarly articles that really get into what are the issues. One of the gaps, the first gap that we noted was patients with chronic pain may face barriers in access to pain care due to being stigmatized as people seeking medications to misuse. Contributing to the stigmatization are the lack of objective biomarkers for pain. Now, this is just an example. This isn't one thing, but I wanted to highlight how in the weeds we got, but without tying anyone's hands. So we wanted people to have the ability to go start to help really push the entire field forward. It's the invisible nature of the disease and societal attitudes that equate acknowledging pain with weakness. So we have recommendations, increase education, increase, understanding of the disease of addiction, counter societal attitudes that equate pain with weakness through an awareness campaign. And ultimately, GAP 2 talks about the national crisis of illicit drug use. This is throughout the report in many different forms. In this particular gap, it notes that the illicit drug use with overdose deaths is confused with appropriate therapy for patients who are being treated for pain. This confusion has created a stigma that contributes to barriers to proper access to care. And our recommendation in that case was to identify strategies to reduce stigma in opioids, so that is never a barrier to patients receiving appropriate treatment with all cautions and considerations for the management of their chronic pain conditions. What you all are doing is exactly that. You are going and reaching out to your elected leaders and ensuring that they understand the difference, and that we have to use the statistics to highlight that these very patients are ironically being mismanaged. Their misuse is really with the guidelines. It is not any longer as an issue as was before. Now, we may have exceptions, but they're not the rule any longer, if that was even the case to begin with. And when I talk about misuse of the CDC guidelines, once again, it was meant for primary care providers, but this has been misused more so than prescription opioids. I think that's something that's great to say and tell people, that it has been applied in the manner that it was not intended. So there was a misinterpretation by a lot of law folks, a misapplication of the state laws and regulatory agencies and health insurance plans and retail pharmacies to get involved, utilizing guidelines, once again, only intended for primary care providers. These guys don't have the understanding. This was all legally to save themselves from any question whatsoever that they had any part in overdose deaths. And the truth is, once again, there wasn't any understanding or appreciation of what the illicit drug crisis is. That to go after that meant to go after drug cartels and secure the border from getting these horrible goods across the border, and changing our perspective on it. It's much harder to go after that than to go after retail pharmacists and doctors and nurses. People who follow the law are trying to do good. And we know that this is a concept that has been supported by hundreds of different professional medical organizations, respectfully, who were really actually just looking out for their patients, many of them patient advocacy groups like the US Pain Foundation. And again, the emphasis on individualized patient care guidelines, not hard stops through education, time, clinical administrative burdens, and looking at how the individual patient needed the time, needed the understanding, and not one size fits all protocols. Suicide due to pain is up. We had always highlighted this graph that showed suicide decedents for ages more than 10 years old. It went up to 2014. It's a very, very hard study to do. It was done within the CDC by really committed good people. And, you know, their first thing when I talked to them about the study was, it was clear that these folks who had committed suicide with chronic pain were very hard to delineate, because oftentimes there's a stigma to suicide and there's a stigma to chronic pain, but what they felt was it was clearly underestimating. And we've heard more and more reports since that time of the number of pain suicides going up. And if you follow this on Twitter, it is heartbreaking. It happens so often when someone will share on Twitter that yet another one of the people with chronic pain has committed suicide. And then just back to our task force, it's really essential that this is put out there. It's a document, once again, that came from Congress, and we executed it. We did it with absolute professionals in pain management, in mental health, in having patients, veteran service organizations, et cetera. And this is what we came with in a nutshell: 5 broad categories of different pain management treatments that provide tools. They're not meant for everyone because everyone is different. They have different comorbidities, different metabolism, all kinds of issues and preferences. But medicines, opioids and non-opioids, there are a lot of different classes we cover. Restorative therapies, PT, OT, aquatherapy, interventional procedures, important when the right subpopulation is identified to help them, behavioral health approaches, and complementary integrative health. And then the 4 policy issues that we wanted to ensure that we saw everything through the lens of was risk assessments or risk benefit analysis. So physical therapy may be great for some, but maybe have more risks for some people than others because of the risk of fall or fractures, et cetera. So that is what risk benefit analysis means. Same goes for opioid or interventions or anything. The stigma issue is big. It has only grown. It's a big barrier to care, something that we want everyone to see through that lens. Access to care continues to be challenging. It's based on workforce. I think some of telehealth, which we really recommended early on, is helping some of that, but we need more doctors and providers who are willing to really come together and with all the tools that are out there, give the care that people need. And of course, pre-authorization and insurance, et cetera, also play a much, much bigger role in pain care. And then education for all of our elected leaders, I think, is a really important place to start. You guys have a big role in that. And we really thank you for what you're doing ahead of time. Ultimately, the bottom line was individualized, multimodal, multidisciplinary care. And here are some graphs that might help some of our elected leaders. We showcase that on the left, patient A, B, C, and D have different issues, different concerns. They get a diagnostic evaluation through a biopsychosocial approach, meaning the same thing we always think. We look at somebody, think about what is the biological basis, how are they doing? Is this affecting their ability to interact, to go to work? And then, of course, what are the limitations in their own social life? A therapeutic alliance is made in a shared decision-making with an extensive pain management toolbox. This is not representative of all the tools. This was just a nice diagram that we got people to make so that we can show as an example the many things we're talking about in addition to opioids. Opioids are there. It's a short term, but it was just, again, an example. It wasn't that we believe in something or not. We just wanted to highlight that we are looking to give patients what they need to get their lives back, and integrate that treatment plan. Again, sometimes for some people, it might just be interventions. Sometimes for some people, it might just be a medication. But you want to consider what, in their case, oftentimes it's in parallel, in my view, to get them to the best outcome. And then you see patient A, B, C, and D. These are just examples, all requiring maybe different tools. Our point to the elected leaders is you can't say this is not some mechanical car that's out of brake fluid and that, you know, the protocols put brake fluid in. It is obviously much more complex as people. So it's just a reminder for them. It goes into some more diagrams of how we look at things. Again, we were way ahead of the curve. Pre-pandemic, we were advocating for telehealth so that our folks can actually get some help. Behavioral health is one of the things that telehealth is really good at, but we've also established that for follow-ups in particular, seeing your providers, that we can say, hey, we're seeing our patient every 2 weeks or on a new medicine, and here's how well they're doing. That way they don't have to come in, and many of them are physically challenged and financially challenged. And so telehealth video visits have been really nice in the follow-up realm. And of course, it's really all of the above that we need. And all kinds of other things, telementoring, risk assessment, I mentioned, risk-benefit analysis. I know my colleagues in medicine do this, but I think we need to really emphasize we're doing it for the sake of the patient so that they know that considerations are there and that there's no perfect outcome. It is a risk-benefit analysis. Even inaction to not treat someone with a medicine, as in an opioid, can lead to great risk, meaning the patient is not functional. The patient may have a risk of blood clots because they're not functional. We want them to ambulate. We need them to do physical therapy. Whatever it is, there's a risk to action and inaction. And for each and every one of the tools that are there, you have to consider that. And I say this to you because we can't have medicine look like it's dumbed down, because that's when those people out there think they can weigh in and take very challenging situations and just put a state law there. That the legislation of medicine is a very slippery slope. And I urge all of you to ensure that what we do ask for is ultimately a clinical judgment, clinical care with a therapeutic alliance between the doctor and the patient, and not to have the intimidation of our providers, of our doctors, by regulatory agencies. It is inconceivable. Now, if there is fraud, that's different. If there's someone who has an MD, DO, NP, or something behind their name and they're committing fraud, they're no longer actual clinicians. They are doing something different. But what we're talking about is the practice of medicine and the art of medicine. And again, the stakeholders, what you all are doing when we talk about public education, you're going to the very last one, policymakers, legislators, regulators. This is called for in the task force by the most expert people in government and outside. And please utilize this. When you're going there, you're going by what the task force recommendations were. And ultimately, what we really need is better quality data for long-term opioids. A large study in North Carolina, some of you know, Cindy can give you more updates on it, showed a low morbidity mortality when they looked at the entire state and opioids there. And this is a study that all the people who are against opioids try to demolish, but it was actually done objectively by someone who didn't have an agenda. We really want better studies to identify that subpopulation that may benefit from long-term opioids, considering genetics, risk factors, medical conditions. Consider that patient variables exist and affect pain, and what treatments are clinically indicated. Have opioid tapering guidelines, as in individualize it. I've had patients who were motivated to come off opioids, but were very, very scared. And I basically said, we don't have to make a fake timeline. Let's do this in a manner that suits you. We'll take pauses when we need it. It took us 2 years, and we didn't even go to zero. We just lowered it to the point where the patient felt comfortable. That is actually really good medical care, and it does provide reassurance. We also talk about opioid and benzos having increased risk. Therefore, we need addiction and pain both to work together in this, and not just an absolute mindless, no, none of this. You can't have the two. No, there are exceptions. People have panics, have severe anxiety disorder, and they may have a chronic pain condition. It's as if we're saying it doesn't exist. And again, we don't want these things to be loosely done without thought. We also don't want to take things away loosely without thought. And ultimately, I can tell you the American Society of Anesthesia and other surgical societies are developing and updating acute pain guidelines for common surgical procedures, something we called for. And I know many other entities, companies are doing their best in terms of trying to help. There's a company called DisposeRx, and at Walgreens and Rite Aids, I've seen their powder for people who do take opioids and are concerned that they don't want it to get in the wrong hands. They've made this powder that you just put the opioid, it dissolves with water, and it's no longer extractable. But people are doing that so that we as a society have reassurance that patients, are having less opportunity for other people to come and steal their drugs or something. I always see them as partners in this because they really aren't trying to limit, they're trying to help. And again, these are the safety announcements by FDA all the way back in April 2019 about the harm from sudden discontinuation of opioid medicine. CDC and the New England Journal of Medicine also put out one. And this is all because of our report warning and them knowing that they can't ignore it. And ultimately, we've always advocated for balance and moderation. We need science, not activists. We don't need agendas. And again, we have people on the Hill. I know Senator Cassidy remains a friend, but there's so many others too who are friends. There's some people who would become friends if they really saw for just a moment what we're talking about. And here's, again, I think always my favorite cloud to highlight how challenging the topic is that we're talking about. It's not just one condition, and it's not just one side effect or bad effect. All our helplines, and thank you so much.
Thank you, Dr. Singh. That was a great presentation. Really, really appreciate it. So if you stop sharing, great. Okay, thanks. Thanks so much. And I'm sure we've got questions from the audience. So can I ask, have there been questions that come in for Dr. Singh?
Hey, Cindy. Yeah, we have gotten a lot of questions. A lot of them are touching on a lot of the same things, which I know you'll get into in the second half of the presentation. But a lot of people are just generally wondering, what all can be done? How can we get more statistics about pain, and how do we reach out to everybody to try and get some of these changes and get this care more widespread across the country?
I'm sorry, can you say that one more time?
Sure. Yeah, a lot of the questions, which I know, again, Cindy is going to get into a little bit later, will be kind of just what steps can people take? What should they do to try and get multidisciplinary care more widespread, and kind of people, maybe physicians and providers, kind of held a little bit more accountable to kind of follow this report? A lot of people are asking a lot of these similar questions around that.
Here's the thing, like, we had really hoped for greater dissemination, and to the best of our ability, we did that. But the report is online, and I know Cindy and the US Pain Foundation can send it out to everybody, but I would take that and send it to them. And actually, it's such an extensive, broad, and deep report because it needed to be. I mean, it's not a simple thing. And if we put simple things, that those would be misused too. So we really wanted to get into specific situations. So for example, I saw somebody say, how do you reconcile the CDC guidelines and the task force report? Well, the task force was tasked to also review the CDC guidelines. We have an entire section that actually notes what should be done with the CDC guidelines. And I would take that, for example, a section, and you can take it into your elected leader or send it to their offices and have people there, where we were actually really balanced. We didn't even say demolish it, which sometimes I feel like We should have, but what we were trying to do at that very specific time was, note the key things that needed update and re-emphasis. So one of the things that the CDC guideline says is ultimately it's the clinical judgment, right? We're like, re-emphasize that, please. Re-emphasize that it's just for the primary care doctors. We also say update that a 90 MME arbitrary number. It may be what you're saying is fine, but for some people it's too much because of their genetics, right? They don't have a great P450 ability to metabolize it. We use this as an example, and it's true. I've seen people who cannot tolerate opioids. Similarly, a 90 MME it may not be great for a lot of other people who are clearly tolerating it, not misusing it. The analgesic effect stays, and they have a more robust life. So what we were saying is don't put these arbitrary lines, or if you're going to, then you need to say, ultimately, it's a clinical judgment. There's a lot of different, very straight, excellent pieces on the CDC review that I really want everybody to go and look at. And the way to really get your doctors to do this is if they have action, they can always in their notes cite the task force, congressionally mandated task force, the recommendations. Go to their state boards too. What we need our doctors to go to their societies and state boards and send it in and say, this is out there. It's from the federal level. This is what it's saying. And, we need the ability to follow this. The problem is that there are people still in government who have an agenda and are continuing to pummel opioids and chronic painful patients and stigmatize everybody because their agenda is really about the big pharma. And that's what's driven this. It's talking about billions, millions of dollars of settlement. And the collateral damage are good people across the nation who have suffered greatly. And I can tell you, there are doctors who it's fear for them. I don't think people are really enjoying it. And I've told Cindy, the challenge is that you've got people on both sides, the patient and the provider. Provider feels this great pressure. They're hearing about their colleagues shutting down practices or going to jail. And then on the other hand, you have patients who are suffering and are being treated really in the most inhumane of fashions. And when these two clash, it only makes for a worsening situation. The alliance needs to be there, the understanding of each other, and then how can it be done and how do you bring in other people? I get a lot of patients whose doctors are concerned about the medicines that they're still on. And then I reach out to the doctor, and all of this is a little bit time consuming. And then I understand from the doctor often, they have a really good relationship with them and et cetera. So that gives me the ability to further trust and then give them kind of the backing that's needed, correctly so. And I'll always be true to what I believe needs to be done. So it's not like I'm all for anything. It depends on the patient and what treatments are right for them. And I can also change, because if someone doesn't respond well to something, that's important. And then we modify, we individualize.
Thanks, Dr. Singh, so much for that really good explanation. And you're right, people can bring this report to their doctors. But the other thing we can do is we can make Congress aware that this report was asked for. It's out there. It was endorsed by 160 organizations. And just like they gave CDC money to distribute the guidelines to every state health department, this report could be distributed to every state health department, every medical board, and educational tools could be developed off of it for physicians. And we want to be sure that Congress urges HHS to do a better job distributing this report and getting it out there and endorsing it, understanding it was mandated by Congress, and that there's many things for frontline physicians to learn from the report. And that's a great segue into us talking about our Advocacy Day and how we're going to work to promote the report and what's in it. We're going to hold questions till the very end now so that we can talk more about how we're going to get Congress to really endorse this report and get it out there. So thank you again, Dr. Singh, for the fabulous presentation that you gave. And we're now going to talk about the way to get it out there. So in my mind, the only way to achieve the vast improvements in pain care that we know are needed for the 50 million of us is for us to advocate for them. So we're asking everyone to join US Pain Foundation this Thursday, October 28th. Congress is in session for our virtual advocacy day, and we're going to focus it on Capitol Hill with the hashtag #PainCareNow. Our ask of our representatives is to urge HHS to disseminate this report to the nation's frontline providers. It's critical that we make providers aware of the full range of treatments for chronic pain, that they're multidisciplinary, that they're coordinated, and that great graphic that you showed, Dr. Singh, of all of the various categories of the report very carefully goes into the full range of treatments that we want available for people. The other thing we're going to do is urge Congress to tell the Centers for Medicare and Medicaid to improve the coverage of a broader range of treatments, including non-pharmacological treatments. You know, CMS has a big role to play here because they're the public provider. I mean, CMS pays for Medicaid, Medicare, and Medicaid. Medicare, as we know, are all the people who are disabled, many of those who have chronic pain, since it's the #1 cause of disability, and people over 65 who have a disproportionate amount of pain. They need access to a broader range of treatments, and that's what we want to ask Congress to do. So from 9 to 5 this Thursday, October 28th, we're going to have as many of you as possible ask your members of Congress these things. And everyone has 3 representatives. You know, we have our representative of the House and our 2 senators. The most impactful thing you can do is call their offices, either the local office or the district office, and say the magic words, "I am a constituent." And then why you care about this issue. You know, I'm a person living with chronic pain, and connect why you care to our ask. So for example, in my case, it took me 5 years to find help. You know, if the task force report in the form of educational briefs went to doctors, I might have been able to find care much sooner and save all those wasted visits to doctors who knew nothing about how to manage pain and didn't know that there were these range of options. And imagine the cost savings that would happen if every person, I mean, I run a support group for people living with pain, and I've run for 20 years. Every single person has had to go to multiple providers before they can find anybody to help them for their pain. You know, if they had that report, think how valuable that would be. The other thing we can do is we have an automated email system where you write one message telling your story and why this dissemination of this report is so important. And you know, it automatically sends a message to all 3 of your congressional representatives. We're going to send that link to everyone who registered today, and you can then forward that to as many other people as you can, and that'll automatically send a message for you. You just create the one email. And then, of course, social media, using hashtag #PainCareNow. There's also many tools on the web. One tool that we found, which is www.commoncause.org, find your representative. You put in your address and it gives you back all the social media handles of your representatives. Please tweet at your representative these asks. Also, following US Pain social channels on Thursday. So Facebook, we're at US Pain Foundation, or Twitter at US_pain, and reshare our messages. For example, here are some tweets you could do. You know, people with pain do not receive the care they need. And there's my rep, Representative Kay Clark. You put your rep's Twitter handle in there. Please urge HHS to distribute the CARA-mandated pain management best practices report to doctors around the country, because we need better pain care now. Doctors haven't always believed me. How many of us have been there when I explain my symptoms? You can take steps to change that. Please help people with chronic pain receive access to multidisciplinary care that they deserve. Pain care now. No, we need better access to pain care now. Tell HHS disseminate the pain management report to providers across the country and help the 50 million Americans living with chronic pain. So those are just some ways you can participate. And just looking at the time now, we have just a few minutes left. I'm wondering, Scott, if we have any other questions that have popped up in either how to participate or in any questions on Dr. Singh's presentation.
Some of the other remaining questions that we have, a lot of great things, and thanking Dr. Singh for her time today. But in particular, people are asking, is there a way to incentivize, I guess, providers or doctors kind of earlier on in their career to kind of get started on a whether it's a pain management fellowship or something like that, so they're more invested out of the gate?
Dr. Singh, that's a good one for you.
Yeah, I can absolutely take that. So I actually do train fellows, and I have even given letters of rec just this year to people outside of our Stanford residency in anesthesia, and both of them are going to excellent places, UCLA and Penn. And I just, they're such good people. I can see the empathy. And so I agree, these are the type of folks who find the satisfaction, they feel that they can do something, and empathy is such a key part of it. So we've been trying to do that. The field is really interesting when people see it as a multimodal field, meaning there you could do medication management, there's integrative, interesting, holistic, nutritional aspects that are coming into play that I think feeds a lot of, there can be proactive health and wellness. Of course, there's interventions, and it's a slew of different conditions. You have to get it well versed with the nervous system. And I think that is what's amazing, is you really come across people who have a commonality of a challenge, and yet they somehow are helping themselves and others. And that's inspiring. So I try to have people see that side of it. And, I think for our young doctors, in this age, everything is algorithms and a dumbed down medicine. And you know what? It's when you talk about this in its multifactorial, kind of this vivid, three-dimensional way where it's humanistic, it moves them. It is what is the antithesis of burnout. Burnout's happening to these young docs because they're like on the computer and they're like having to document everything and put all their caseload in. But it's the human quality aspect that actually gives you back time. And I think that's why sometimes when you go in and you see a physician or a young doctor, if you share some of that look, it means so much to you, you'll give them and remind them about the real reason that anyone should go into medicine. And that's just that connection and feeling like you're doing something worthy. Otherwise, right now, they've just, put it down to like the masses and on a computer and just entering data. And like, it doesn't matter what your clinical judgment is, you're limited anyway. That is the sad thing. So I think people here who themselves may have chronic pain can actually be the motivating reason to get a young doctor into pain management.
That's great. Thank you, Dr. Singh. And I know we at US Pain Foundation often give talks or asked to give talks. I've spoken to Tufts medical students and Johns Hopkins medical students. And that's a really important thing. I'm just, gave me a great idea, Dr. Singh, that I want to talk to you about later on. But
absolutely. Yep.
Yeah.
I'd love to.
It's just a great idea to talk to medical students, and couldn't we really influence them? So thanks for that question. So we're out of time, but I just want to encourage everyone to participate this Thursday. Thank you so much for joining us. I really believe that together we can really make a difference improving pain care for all Americans. And let's get out there and advocate. If 50 million Americans ask for better pain care, let me tell you, we would definitely have it, because our elected officials would hear from us. So thank you again, Dr. Singh, for what you've done and for all you do for pain patients. We really
absolutely. It's my honor. Thank you, everybody. Appreciate it.
Okay.
Thank you.
Bye-bye, everybody. And thanks so much for joining us.